Hello, it's me again, Professor Kemper. Surprise. So, welcome. We're going to be talking about ECG interpretation today, and for many of you, this is an exciting subject, and for others, they don't love it that much because you know what? Over a period of time, you're going to start to understand this. Initially, it's going to be difficult. I'm not going to lie, but stick with me, okay? We're going to go over it today and then we're going to go over it again in class. So if you have questions, write them down. We'll talk about it in class together. So we have our student learning objectives today, and I know that you've already kind of dipped some toes into this last semester in Adult Health 1, where you learned some cardiac concepts, as well as some basic ECG rhythms. And today we're going to go over some more basic ECG rhythms and kind of add to your repertoire of, interpretation, if you will. So let's do it together. So let's start with the normal electrical conduction. So this slide shows us the normal electrical pathway of the heart. So this is the sequence that must occur for us to have effective cardiac contraction and cardiac output. And every rhythm we interpret later is a variation or a disruption of the normal pathway. So starting with the sinoatrial node, the SA node, this is the heart's primary pacemaker, and it's located in the right atrium near the opening of the superior vena cava. So the SA node has an intrinsic firing rate of 60 to 100 beats per minute, which corresponds to normal sinus rhythm. And when the SA node fires, electrical impulses spread across both atria, and it causes atrial depolarization, which we see as the P wave on an ECG. And because the SA node fires the fastest, it normally overrides all other pacemakers in the heart. So after the SA node fires, these impulses travel through the internodal pathways. And these pathways allow the impulse to spread efficiently across the atria, and it ensures coordinated atrial contraction. So it's pushing the blood into the ventricles before ventricular contraction. And this is also known as atrial kick, which contributes significantly to ventricular filling, especially this is going to be important when we talk about atrial fibrillation, atrial flutter, and this is going to come into play when we talk more about older adults and patients with heart failure. We won't talk too much about heart failure until next semester when you get into Adult Health 3, but we'll dabble a little bit. I'll bring it up because we're going to talk about MIs, right? So how can you talk about MIs without heart failure? All right, so next we have the atrioventricular node, and the impulse is going to reach down after we've started the SA node, electrical conduction. Now we are reaching the AV node, which is located at the junction of the atria and ventricles. So the AV node has an intrinsic rate of 40 to 60 beats per minute, and its key function is intentional delay of the electrical impulse. So this delay allows the ventricles time to fill completely before they contract. And on the ECG, this delay corresponds to the PR interval. And then we get down to the bundle of His and bundle branches. So after the AV node, the impulse travels through the bundle of His, and the bundle of His divides into the right and left bundle branches, which delivers the impulse towards the ventricles. And these structures have an intrinsic rate of 20 beats per minute or less. So conduction through the bundle branches ensures simultaneous ventricular activation, so that squeeze of those areas. And then we have the Purkinje fibers. So these distribute the electrical impulse throughout the ventricular myocardium, and this results in rapid coordinated ventricular depolarization. And it's going to correspond to the QRS complex on the ECG. So this coordinated contraction, it produces effective ventricular ejection and cardiac output. So understanding this normal pathway is really critical because every dysrhythmia we'll learn can be traced back to where is the conduction altered, delayed, or blocked along this pathway. Terminology to know. So these terms come up repeatedly in ECG interpretation, medication effects, and clinical reasoning questions, especially when we talk about medication management after an MI. So things like electrical stimulation or depolarization. It refers to electrical stimulation of those cardiac cells, and it's going to occur when sodium and calcium ions move into the cell, which triggers an electrical impulse. And depolarization leads directly to myocardial contraction. On the ECG, we'll see atrial depolarization, which is equal to the P wave, and ventricular depolarization, which is equal to the QRS complex. And then we have electrical relaxation, which is repolarization. So repolarization is the process of electrical recovery and relaxation of the cardiac cells. And during repolarization, potassium moves out of the cell and restores the resting membrane potential. On an ECG, you'll see this in ventricular repolarization, which is the T wave. And again, repolarization is going to allow the heart to prepare for the next depolarization. And then we have chronotropy, which refers to heart rate and how fast the heart beats. So a positive chronotropic effect increases the heart rate, and a negative chronotropic effect decreases the heart rate. So the SA node is the primary structure responsible for chronotropy. And a medication like here, some beta blockers, calcium channel blockers, can be negative chronotropes, decreasing the heart rate. And then we have dromotropy, which refers to the speed of electrical conduction, especially through the AV node. So a positive dromotropic effect increases conduction speed, whereas a negative dromotropic effect slows conduction. And lastly, we have inotropy, which refers to the force of myocardial contraction. So a positive inotropic effect increases contractility, and a negative one decreases that contractility. Now let's talk about influences on heart rate and contractility. So heart rate and contractility, they're not fixed. And this slide summarizes the major physiologic and external factors that influence how fast the heart beats and how forcefully it contracts. So we have the autonomic nervous system, and this is primarily a short-term regulator of heart rate and contractility. We have the sympathetic nervous system, which can increase the heart rate. We get positive chronotropy, and it can increase contractility, where we have positive inotropy. And that acts through the beta-1 adrenergic receptors. We also have the parasympathetic nervous system, which is going to primarily slow the heart rate and act via the vagus nerve on the SA and AV nodes. It really has minimal effect on ventricular contractility. We can have hormonal influences like catecholamines, which are epinephrine and norepinephrine. These can mimic sympathetic stimulation and increase heart rate and contractility. We have thyroid hormones, which can increase metabolic demand and lead to increased heart rate and enhanced cardiac responsiveness. And when we get to, towards the middle of the semester, we'll start talking about that. Other factors include exercise. So during early exercise, we have withdrawal of parasympathetic vagal tone. And as exercise intensity increases, we have sympathetic activation, which tells the body we need to increase the heart rate and contractility to meet that oxygen demand. Caffeine, stress, and emotions, these factors stimulate the sympathetic nervous system and result in increased heart rate, increased contractility. Emotional stress can also trigger dysrhythmias in susceptible patients. Age and fitness level. So with improved cardiovascular fitness, sometimes we see resting heart rate typically decrease. Stroke volume can increase due to stronger myocardial contraction. Aging can also be associated with decreased responsiveness to beta adrenergic stimulation. And then other influences like medications, we talked about beta blockers and how they can decrease heart rate or cause negative chronotropy, and they can also decrease contractility, which is negative inotropy. These are commonly used in hypertension, dysrhythmias, and heart failure. And then we have calcium channel blockers, which can decrease calcium entry into cardiac cells, reducing contractility, and for some agents, slow that AV conduction. So when a patient's heart rate or blood pressure changes, you should always be asking, is this a nervous system response? Is this a hormonal response, a medication effect, or a physiologic adaptation? And that's how you move from memorizing things to your clinical reasoning. So before we interpret rhythms, we really need to understand what an ECG actually shows. And just as importantly, what it does not show. So what a lead is, an electrode is placed on the skin and it detects electrical activity. And when electrodes work together, they create an imaginary line of view called a lead. So a lead represents the heart's electrical activity from one specific angle or perspective. And this is why placement matters. So electrodes are placed in specific locations on the chest and the limbs, and each placement allows us to look at the heart's electrical conduction from a different side or region. So that is why poor placement can result in false ECG changes. So it's important that you know where to put these and that they're properly placed. Some types of ECG monitoring. So ECG monitoring can use 2 to 5 electrodes, typically continuously monitoring that patient. They're best for detecting rate and rhythm. And then we have the 12-lead ECG, which provides the most comprehensive view of the heart's electrical activity. Although it uses 10 electrodes, it generates a 12 different lead view. And the 12 lead primarily reflects electrical activity of the left ventricle, which is the main pumping chamber. This is why a 12 lead is the gold standard for evaluating ischemia and myocardial infarction. So any changes in electrical conduction appear as changes in the ECG waveform, so they might change the shape, height, or duration. And these waveform changes give us clues about ischemia, infarction, any conduction abnormalities, or electrolyte disturbances. So if symptoms or findings suggest involvement of areas that aren't visualized well, we might put additional leads on to the patient, just as an FYI. So this slide is about 5-lead ECG monitoring, which is what nurses use most often at the bedside for continuous rhythm monitoring. So in 5-lead monitoring, we place 5 electrodes on the chest. So these electrodes allow the monitor to create multiple lead views, even though we only place 5 stickers. And the goal is to get consistent, clear electrical signals from the heart during routine monitoring. So starting in the right arm, the white lead that says RA, this is placed on the right upper chest just below the clavicle, and it acts as one of the negative poles for several limb leads. It's important for creating lead 1 and lead 2 views. So if the right arm lead is misplaced, our P waves and our QRS size can be distorted. Moving right to the left arm, that sounded weird, but now we're on the black lead that says LA in the picture. This is placed on the left upper chest below the clavicle, and it acts as a positive pole for lead 1, and it helps determine whether electrical impulses are moving towards or away from the left side of the heart. So RA and LA help us look across the atria. Then moving on to the left lower side of the picture, which is the right leg. This is placed on the right lower chest or abdomen, and it serves as the ground electrode. It does not create a lead view. It stabilizes the signal, but it doesn't show any cardiac activity. And then we have the left leg, so the right side of the chest, the red lead that says LL. This is placed on the left lower chest or abdomen, and it acts as a positive electrode for lead 2, which is most commonly displayed when nurses are monitoring their patient's cardiac monitor. This placement lines up with the normal electrical flow from top right to bottom left. We love this lead because there's clear P waves, easy rhythm interpretation, and matches cardiac physiology. And then finally, the chest lead, or the V. This is the 5th electrode and the only one you move depending on what you want to monitor. Most commonly, it's placed in V1, which is best for atrial activity and bundle branch blocks, or V5, which is best for ventricular activity and ischemic monitoring. You can only monitor one chest lead at a time in 5-lead ECG. These images represent what the monitor does with electrical signals. So if the electrical impulse is going towards the lead, we're going to have an upward waveform, or if it's going away from the lead, we have a downward waveform. Sideways to the lead, it's flat or isoelectric. So this is why proper electrode placement ensures the heart's electrical activity is being viewed properly. So let's go into the components of an ECG. So when we look at an ECG strip, we're really seeing a story of electricity moving through the heart over time. And each part of the waveform corresponds to a specific cardiac event. So let's start with the isoelectric line, or also known as baseline. This is a flat baseline of the ECG, and it represents a period when there is no net electrical movement towards or away from the lead. This doesn't mean the heart has stopped, it means the electrical charges are balanced. Then we have the P wave. The P wave represents atrial depolarization. So the electrical impulse, again, is going to begin in the SA node and spread through the atria. This electrical activity causes that atrium to contract. And a normal P wave is 0.12 seconds or less. There should be one P wave before every QRS, which suggests the rhythm is sinus in origin. And any abnormal P waves may indicate atrial enlargement, atrial dysrhythmias, or ectopic atrial pacing. Then we have the QRS complex. The QRS complex represents ventricular depolarization. This is the electrical event that triggers ventricular contraction. So because the ventricles are larger and thicker than the atria, the QRS complex is going to appear taller and sharper. The QRS duration is going to be 0.12 seconds or less. So if the QRS is wide, the ventricles are not being activated normally. A widened QRS may indicate a bundle branch block, ventricular rhythm, or medication or electrolyte effects. The T wave represents ventricular repolarization. This is the electrical recovery phase that we were talking about when ventricular cells reset in preparation for the next beat. And this allows the ventricles to relax and refill. So any abnormal T wave changes may indicate ischemia, potassium imbalance, or effects of medications. And there is no visible atrial repolarization wave because it's hidden inside the QRS complex. So up to this point, we've talked about what the waves represent. Now we're going to talk about how long things take, because the timing tells us whether conduction through the heart is normal or delayed. So we have the PR interval, which is measured from the beginning of the P wave to the beginning of the QRS complex, and it represents the time it takes for the electrical impulse to travel from the SA node through the atria, through the AV node, and into the ventricles. So a normal PR interval is 0.12 to 0.20 seconds. So any prolonged PR interval, we're thinking about an AV conduction delay, maybe a first-degree AV block. In a short PR interval, the impulse is bypassing the AV node. Then the ST segment. The ST segment starts at the end of the QRS complex and ends at the beginning of the T wave, and it represents the time when the ventricles are fully depolarized. So normally the ST segment should be isoelectric, meaning it sits on the baseline. And we look at this ST segment and assess for myocardial ischemia or injury. That's when we get it not sitting flat on the baseline. It either rises or lowers. So it's above or below that isoelectric line. And it's indicating possible ischemia or injury to the myocardium. Next, I'm going to talk about the ECG grid paper. So each small box on the ECG paper represents 0.04 seconds. And one large box, or 5 of those tiny small boxes, equals 0.20 seconds. And then we look at the vertical measurement. So vertically, 10 millimeters equals 1 millivolt. And this is going to help us assess voltage. And so we look at voltage for hypertrophy, but for now we're really going to focus on the horizontal timing, so the little boxes. So we look ideally at a 6-second strip, which contains 30 large boxes, and this length allows for accurate heart rate calculation and regular rhythm regularity assessment, especially for irregular rhythms like atrial fibrillation. So now that we've gone over the components of an ECG, we're going to start talking about the steps to interpret an ECG, and we're going to be practicing some strips together in class. So whenever you look at an ECG, heart rate is always going to be your first step. So before naming a rhythm, we have to know if the heart rate is normal, fast, or slow. And so there's a couple of different methods. So method 1 is the small box method, and this is the most precise. So the small box method is a way to calculate the heart rate. We count the number of small boxes between 2 consecutive R waves. So remember QRS. So we're looking at the R waves, like the peaks on the ECG. And we're going to divide that by 1500. Why are we dividing that by 1500? Because remember, each small box is 0.04 seconds, and 60 seconds divided by 0.04 is 1500. And this is best used for regular rhythms when we want exact precision. So if the rhythm is regular and you want to be exact, use the small boxes. The second method is the big box method, which is fast and practical. So we count the number of large boxes between the 2 R waves and we divide that by 300. So this method is quick and it works well at the bedside. So why are we dividing each large box by 300? Remember that each large box is 0.20 seconds. So 60 seconds divided by 0.20 is 300. And this is best used for regular rhythms and quick estimates. And then finally, method 3, this is the 6-second method. This is great for irregular rhythms. So we're going to identify a 6-second strip and print that out. And we're going to count the number of R waves in those 6 seconds, and we're going to multiply that number by 10 to estimate beats per minute. And again, this is best for irregular rhythms like atrial fibrillation or rhythm strips without consistent RR intervals. So every time you see an ECG strip, your first step should be, is the rhythm regular or irregular? We're going to choose the appropriate method for interpreting the heart rate, and we're going to determine if that rate is normal, fast, or slow. So once we know the heart rate, the next question is how consistent the rhythm is over time. So rhythm regularity tells us a lot about where the impulse is coming from. So you need to ask yourself, is the rhythm regular or irregular? A regular rhythm has consistent R-to-R intervals across a strip. An irregular rhythm has variation in the R-to-R intervals, and we always assess regularity before naming the rhythm. So you want to measure the distance from peak of one R wave to the next. And you can either use the ECG grid, you can use calipers, or kind of mark a paper with pencils to measure that R-to-R interval and see if it's regular or irregular. And we're going to compare across the strip. So you're not measuring just one pair of beats, you're going to compare the R-to-R intervals across the strip. And any minor variation can be normal, especially with respiration, but a rule of thumb, if the R-to-R intervals differ by more than about 0.12 seconds or 3 small boxes, the rhythm is irregular. And we can have types of irregularity, so we can have a regularly irregular pattern. For example, some certain heart blocks, or when we get to talking about premature atrial contractions or premature ventricular contractions, they can be in a regularly irregular pattern. We can also have an irregularly irregular pattern, so we have no predictable pattern, and this is really classic for atrial fibrillation. And then we have regular rhythms, which commonly include normal sinus rhythm, sinus tachycardia, sinus bradycardia, and supraventricular tachycardia. So these rhythms usually originate from a single consistent pacemaker. Now that we know the rate and whether the rhythm is regular, the next critical question is the rhythm starting in the atria where it should? So P waves help us answer that. So we want to ask, are there P waves present? And a normal P wave, again, is going to represent atrial depolarization and originates from the SA node. In normal sinus rhythms, P waves should be present, they should be upright, and they should be easy to identify. You're also going to ask yourself, are the P waves uniform in shape? So they should look the same from beat to beat. Also, is there one P wave for every QRS? Each P wave should be followed by one QRS complex. And each QRS complex should be preceded by one P wave. So this reflects intact atrial to ventricular conduction. So when P waves are absent, this suggests atrial fibrillation. We'll talk about that later on. Or it could be a junctional rhythm where the impulse is originating near the AV node but not in the SA node. And then when there are extra P waves, more P waves than QRS complexes, this is going to suggest either atrial flutter, atrial tachycardia, but we know that the atrial activity is faster than the ventricular response. We also might assume that we have P waves there, but they may be hidden in the T wave or hidden in the QRS. Sometimes we lack visibility of P waves, but it doesn't always mean that they're absent. So at this step 4, we're asking a very specific question, which is the electrical impulse moving from the atria to the ventricles at a normal speed? So we're looking at conduction. And is this conduction consistent? So we do that by measuring PR interval. So a normal PR interval is 0.12 to 0.20 seconds. This is equal to 3 to 5 small boxes on the ECG paper. And again, this PR interval represents conduction through the AV node. So ask yourself, is the PR interval consistent? Are we measuring the PR interval on multiple beats, not just one, to look for that consistency? In normal conduction, the PR interval should be within range and the same length from beat to beat. And consistency is going to tell us that the AV node is behaving predictably. You also want to ask yourself, is the PR prolonged or is it variable? A prolonged PR interval is greater than 0.20 seconds. That means the conduction is too slow, but it's still intact. And we look at this and say, this is a first degree AV block. So everything's getting through, but it's just delayed, it's late. And then for a variable PR interval, where the PR interval changes from beat to beat, we have some P waves, but might not be followed by a QRS. This indicates intermittent failure of conduction through that AV node, and we start to think about a second degree AV block. So at this step, we're asking a simple but critical question, which is, how are the ventricles being activated? So we're evaluating the QRS complex, which is the width and appearance that's going to give us the answer. So a normal QRS complex is less than 0.12 seconds, which equals 3 small boxes or fewer on the ECG paper. So a narrow QRS means the impulse is traveling through the normal ventricular conduction system. So narrow is going to equal fast, organized ventricular conduction. So we want to ask ourselves, is the QRS narrow or is it wide? A narrow QRS is going to be less than 0.12 seconds, and anything that is wide is going to be greater than that. So a wide QRS complex, we have ventricular depolarization that's slower than normal. The electrical impulse is traveling through the ventricular muscle, but not the normal conduction system. So some common causes, we might have a ventricular rhythm, we might have a bundle branch block, or ventricular tachycardia. We also want to ask ourselves, is the QRS uniform or is it bizarre looking? So uniform QRS complexes look similar in shape across the strip, and it suggests a consistent origin and one dominant pacemaker. If they're bizarre or variable, where the shapes differ from beat to beat, may indicate ectopic ventricular beats, premature ventricular contractions, or ventricular irritability. So at step 6, we're looking at the ST segment. We're no longer just naming a rhythm, we're screening for myocardial ischemia or injury, which can be immediately life-threatening. So we're looking at the ST segment, which begins at the end of the QRS complex and ends at the start of the T wave. And it should normally be isoelectric, meaning it sits on the same baseline as the PR segment. So is it elevated, depressed, or is it isoelectric? So always compare the ST segment to the isoelectric baseline. Any small deviations are going to matter. This isn't a big picture assessment. So really looking at each complex and ST segment and saying, is that laying flat on the line, or is it elevated or depressed? So a red flag is when we see ST elevation, which indicates acute myocardial injury. And this suggests an ongoing infarction or full thickness myocardial damage. This is a medical emergency. Another red flag is ST depression. So ST depression typically indicates myocardial ischemia, can be caused by reduced oxygen supply, increased oxygen demand. It can be transient or it can stay persistent. And often when you see ST elevation, ST depression, your patient's going to have symptoms, chest pain, maybe some diaphoresis, maybe some shortness of breath, maybe some tachycardia. So ST changes should always be interpreted with the patient's symptoms, their vital signs, and their clinical presentation. A normal rhythm does not rule out ischemia. So by this point, we've evaluated rate, rhythm, conduction, and injury. So the T wave is going to give us important clues about repolarization problems, often related to ischemia or electrolytes. So what we want to do is ask ourselves, what does the T wave look like? The T wave represents ventricular repolarization or electrical recovery, and in most leads, a normal T wave is upright, smooth, and rounded. So is the T wave upright or inverted? Inverted T waves can indicate myocardial ischemia as well, and it often occurs with chest pain, reduced coronary blood flow, or evolving cardiac injury. We can also look to see if they're peaked or flattened. So peaked T waves, which are tall, narrow, peaked at the top, are classic for hyperkalemia, so high potassium, and it's often described as tented or sharp. Flattened T waves or low amplitude T waves may also be associated with hypokalemia, sometimes certain medications, or general repolarization disturbances. So flattened doesn't scream emergency, but it deserves that investigation. So always interpret T waves in the context of ST segment findings, patient symptoms, electrolyte levels, and medications. This step is going to be a patient safety pause. So we're asking, is the heart taking too long to reset between beats by checking the QR interval? And if it is, the patient's at risk for a dangerous rhythm. So asking ourselves, is the QT interval prolonged? The QT interval represents the total time for ventricular depolarization and repolarization, and it's measured from the beginning of the QRS complex to the end of the T wave. The QT interval varies with heart rate, so we care about whether it is appropriately short or abnormally prolonged. So why does a prolonged QT interval matter? Well, it increases the risk for torsades de pointes, which is a polymorphic ventricular tachycardia that can rapidly deteriorate into ventricular fibrillation. And we don't want that. It can also result in sudden cardiac death. So we have things that prolong QT interval, like medications, antiarrhythmic medications, sometimes psychotropic medications. And the risk increases when there's multiple QT prolonging meds or electrolyte abnormalities. Electrolyte considerations can also be a cause, so low potassium, magnesium also increase QT prolongation, so you should always consider looking at their current labs, recent diuretic use, and their renal function. So up to now, we've been collecting data from the ECG, and the final step is where we transition from interpreting to nursing judgment and action. So using everything you've already analyzed, rate, regularity, P waves, PR interval, QRS width, we're going to name the most accurate rhythm, even if it's a basic one. And we're going to ask ourselves, is the patient stable or unstable? You always want to assess your patient, not just the monitor. And then some signs of instability include hypotension, any altered mental status, chest pain, and shortness of breath, signs of poor perfusion. Sometimes a rhythm that looks scary may be stable, and a rhythm that looks normal may not be. Another question, what nursing action is required now? This is an NCLEX priority question. Possible actions might include continue monitoring, obtaining vital signs, check labs or medications, notify the provider, or prepare for emergency intervention. So remember, ECG interpretation isn't about memorizing those patterns. It's really identifying who's at risk and what needs to happen next.